Thank you so much, and welcome everybody to the National Diabetes Education Program's cross-cutting webinar on population health. We have a wonderful audience, and we have some wonderful presenters. Our audience really are from where people live, work, and play. About a third work for non-for-profits, about a third work for the government, and about a third are involved in the business world. We also have some wonderful presenters with a lot of experience. We have Dr. Loeppke, who is the Vice Chair of the U.S. Preventive Medicine. He is the past president of the American College of Occupational and Environmental Medicine, and he also was the chair of a work group that has updated the National Diabetes Education Program's Diabetes at Work website, which we will look at later. Our second speaker is Dr. Jeanette May, who's a principal investigator of a Robert Wood Johnson Foundation grant that looks at how communities and businesses can get together to improve the health of their communities. So why are we here? Well, right hot off the press in the past 2 weeks, there was an article from CDC researchers in the Division of Diabetes Translation that has shown that the costs to people who have diabetes have increased. And the reasons are that people are accessing more services, and also that people are using more medication, and the cost of the drugs have also risen. So we know that we have an epidemic of diabetes. So what can we do? The goals of this webinar include learning about the benefits of population health management, where we all live, work, play, and actually pray as well. We want to learn strategies to show how work sites, businesses, and community organizations can work together. What are some best practices? Why does it matter? And then the last thing is we want you to learn about resources in the public domain that everybody can access to help them manage diabetes where people live, work, and play. These are resources that everybody can use, providers, consumers, and we will go over those as well. So some background. What is the National Diabetes Education Program? And we always just use the acronym NDEP. NDEP was established in 1997, and we wanted to promote early diagnosis, improve diabetes management and outcomes, and also prevent and delay the onset of type 2 diabetes in people who might be at risk. It's jointly sponsored by the Centers for Disease Control and Prevention and the National Institutes of Health. We also have over 200 partners in many sectors, federal, state, and private sector as well. We also have stakeholder groups, and the group that is really involved in this particular webinar is the Business Health Strategy Stakeholders Group. We have business coalitions, groups such as Population Health Alliance, health plans, state health departments, and also occupational health providers, folks from the American College of Occupational and Environmental Medicine and the American Association of Occupational Health Nurses, and others, of course. We want you to make the community an integral part of your healthcare team, as we said, where people live, work, and play. So I'll turn it over to Dr. Loeppke, who will start our webinar. Thank you, Ron.
Thank you, Dr. Allweiss, and thank you, everyone, for joining today. It's a privilege to share some thoughts with you about population health management, and I have a lot of information to go through. You will have access to all of our slides later, but I'll be moving quickly in the time available. I want to talk about the why, the what, and the how of population health management, why it's important, and delineate the converging trends that are really advancing the value of population health management. What is the business case, why employers are interested, and how actually examining some of the attributes and results of successful workplace-oriented population health management initiatives. First of all, the converging trends. There are epidemiological, political, cultural, and financial trends that are driving the need and the interest in population health management. The epidemiologic trends include the global burden of health risk and chronic illness, the age wave, the so-called silver tsunami about to hit the healthcare system, and the compression of morbidity as one of the potential positive solutions. The challenge, this global challenge, is the epidemic of non-communicable diseases that tend to drive mortality because of unhealthy lifestyle behaviors. We could call it the 5-5-75. The 5 lifestyle behaviors of physical inactivity, poor nutrition, smoking, alcohol, medicine, non-adherence, and 5 chronic conditions, diabetes, heart disease, lung disease, cancer, and mental illness, that impact 75% of the deaths worldwide. The age wave, as we all know, in our baby boomer generation hitting the beaches of our healthcare system, there's over 10,000 people every day turning 65, and there's going to be a lot of demand in the health system, in large part due to a lot of the lifestyle-related illnesses and chronic diseases. One thing to consider, Dr. D. Eddington has shown in many years of research that from a healthcare cost perspective, it's actually the health risk that impacts cost more greatly than the age of the individual or the population. In other words, you can see the costs across the age bands in looking at low, medium, high-risk individuals. For someone that is a individual between age 35 and 44 but is high health risk, on average they have about $5,700 of annual medical costs. Whereas someone that's greater than 75 years old that is low health risk, they also have around $5,700 of medical costs. So actually the risk trumps age in terms of health costs in America. And in the United States, everyone's familiar with the fact that over half of all causes of death are related to lifestyle, that only 20% actually related to heredity. So we can't blame our parents on everything for the illnesses and conditions that we tend to develop. In fact, one of my professors in my preventive medicine residency said, largely how we live dictates how we die in the United States. But some good news is the growing body of evidence and the science of a phenomenon called the compression of morbidity. What we see is that in America, people are born, they get in their late 20s, early 30s typically, and they're at the peak of health, and then in general, society tends to see the health deteriorate over time and actually get to a lower than acceptable quality of life in later years, where they're having multiple chronic conditions on many medications in and out of emergency rooms and hospitals. And the difference, though, has been shown that if people just paid attention to some of their healthy lifestyle, and I'm not talking about being a marathon runner, I mean, actively getting some walking, some physical activity, not smoking, eating healthier, that they could actually postpone the age of this onset of morbidity and compress it so that their life expectancy can be increased by reducing health risks, their quality of life can be increased, but then they can, quote, live healthier longer and die more suddenly at lower cost, or experience, sports metaphor, sudden death in overtime. And the reality is this has been shown now for over a 30-year time frame that this does occur. The political trends. We've seen the Affordable Care Act and the National Prevention Strategy and focus on aligning incentives among consumers and providers and employers around improving population health management and higher quality and lower cost with some of the initiatives of the accountable care organizations, the ACOs, and the patient-centered medical home, the PCMHs. Just as a very brief reminder, the ACOs are a model that make physicians and hospitals more accountable, outcomes-oriented, performance-based goal to improve the value of this health services, control costs, and improve quality. Similarly, the patient-centered medical home is more about a primary care physician relationship and a whole person and a whole population orientation integrated and coordinated care, again, aligning incentives around better clinical outcomes. The cultural trends driving population health management include a phenomenon where I think that health is becoming the new green. In addition to the interest we have as a society in a sustainable external environment, I think there's an increasing interest in the sustainability of our internal personal health environment. And there is the whole social networking game theory applications that are innovating a lot of the healthcare industry and motivating people to maintain better health. And with the mobile wireless technology that's transforming the healthcare industry and the mobile apps, smartphones, what's interesting is mobile technology is the world's most ubiquitous platform. In fact, more people have access to cell phones worldwide than drinking water, electricity, or a toothbrush. And we know from studies that are projecting where this will be that by 2020, it's suggested around 160 million Americans will be monitored and treated remotely for at least one chronic condition. And if there are those of you interested in the movement of the mobile wireless apps that are underway, there may well be a time where doctors even prescribe evidence-based mobile health apps because it allows perpetual connectivity and communication with consumers, with patients, helping translate information into knowledge and knowledge into action and getting reminders and notifications. What about the financial trends? Well, the problem we all are aware of is the cost crisis, but for the most part, it is caused by the health crisis in our society. 75% of U.S. healthcare costs, of the over $3 trillion now spent in healthcare annually, is related to chronic diseases. And for every medical or Medicare dollar spent, it's 96 cents related to these chronic diseases, and for Medicaid, 83 cents. Dr. D. Eddington is a renowned researcher and has over 300 peer-reviewed medical journal articles of his research and published books. But the bottom line is that as health risks go, so go health costs. The great thing is, though, as you reduce health risks, you can reduce health costs. And that's an important phenomenon that's driving the business value of population health management. And we can always remember from the past the Benjamin Franklin quote that an ounce of prevention is worth a pound of cure. So what we also recognize is that the bigger problem to employers is the total cost impact of poor health. By that, what I mean is we were able to do some research and publish some studies documenting that for every $1 of medical pharmacy cost the employer pays out for their employees, on average, there are $2 to $3 of these health-related productivity costs in absenteeism, short-term, long-term disability, or presenteeism, where the worker is present but not performing as well because of a health risk or a health condition that's not well managed. In fact, in that study, we looked at the top 10 medical conditions driving medical pharmacy costs, and you see the typical top 10, with cancer being at the top of that list. But when you add in the costs of the presenteeism and absenteeism, it's a different top 10 list, with depression being the number one medical condition with the highest total cost for the employer community. So it's a element of functional outcomes that we need to include with financial outcomes when looking at the efficacy of care. In fact, in one of the case studies I was able to be involved with, a public company, 58,000 employees, the CFO estimated there were 8 days per employee of health-related absenteeism and presenteeism. And he asked the question, if they got back 1 day per employee per year of that current lost performance, what is it worth to that company? And for them, it was worth $18.8 million to their EBITDA, bottom line. And they traded at a 13 times multiple in Wall Street, so that translated into a $240 million estimated market cap increase. They had 292 million shares outstanding, so it was an increase of 84 cents in per share value if they could get 1 day back per employee per year out of the 8 days currently lost to health-related absenteeism and presenteeism. So the solution is really focusing on evidence-based population health management. We know that preventive medicine is a key component of that because the CDC has shown that 80% of heart disease and type 2 diabetes and 40% of cancer are preventable if people just stop smoking, ate healthy, and exercised. Now, the thing is, we all know that. Our grandmothers told us that. But the challenge is, it says easy and does hard for too many people. And in fact, some people think more of the health of their pet than they do themselves. Therefore, what we see in the industry is this need and this focus on overarching whole population health management that includes primary, secondary, and tertiary prevention. Primary prevention, keeping the healthy people healthy. Secondary prevention, earlier detection and diagnosis through evidence-based screening. And tertiary prevention, early intervention with evidence-based care management to reduce morbidity, complications, and costs of people with chronic conditions. As an example, there is obviously a need for better diabetes population health management. Now, 86 million Americans have prediabetes, yet 77 million are unaware. And of the 29 million Americans that have diabetes, 8 million are undiagnosed. And you can see on down the line of the challenges that we have in really effectively treating and controlling and diagnosing people with diabetes, as well as preventing those from developing diabetes that have prediabetes. We have examples in the literature that talk about evidence-based population health management. This is an example of a study I was able to do with Dr. Eddington and others. We analyzed the health risk assessments, blood test screening results, blood pressure, weight measured at baseline and after 2 years of a workplace wellness personalized preventive plan. We were able to show that there was a net movement out of the high-risk segment of the population, out of the moderate risk, and into lower health risk category. In fact, of the people that started out high health risk, and this is defined as there are 15 individual health risk factors, like measuring blood pressure and fasting glucose, etc. If you have 5 or more of those 15 risk factors that are high, then you're in a high-risk category. If you have 3 or 4 that are high out of the 15, you're in medium risk, and if you have 0 to 2, you're in low risk. Of those starting out high risk, after 2 years on their personal preventive plan, 45% moved down to medium risk, and 18.5% moved all the way from high to low risk. So this is significant and is effective, but I wanted to make sure it was clinically significant and not just categorically significant. So for instance, people that have elevated high-risk blood pressure, means higher than 140 over 90, there were 923 people at baseline out of the 7,804 people in the study that had elevated blood pressure. After 2 years on their preventive plan, 81% of those people, 744 of them, came down out of the high-risk blood pressure category, and actually their mean blood pressure reading was 123 over 77, which is normal. So clinically significant, and the vast majority of those people doing it without medication through lifestyle management. Similar findings related to the fasting blood glucose reductions and BMI and HDL and cholesterol. Now, as an example of population health management, we also look in detail through the claims data. This is an example of an employer that spends over $125 million a year in their medical pharmacy claims costs on their workforce. We analyze what we call gaps in care, and for instance, in that population, there were 1,638 people that had diabetes. Well, 525 of those had not had a hemoglobin A1C test in the last 12 months. So this helps target and know who to reach out to in working with them to see their physician and close those gaps in quality. As an example of 299 people where we had the medical pharmacy claims data 1 year prior to their intervention of being on the diabetes care management program and then 3 years on program, you can see dramatic reduction in hospital inpatient days per thousand and per member per month costs. In fact, when you look over time, the 3-year cumulative cost savings, even after taking into account the costs of the diabetes care management program, the 3-year cumulative savings, $5.6 million on 299 people with diabetes. And think how much those people appreciated not having to be in the hospital as much either. So in summary, again, you'll get the slide and can look at it in more detail, but I think there are unique features and benefits for each stakeholder related to population health management, for the member patient, for the employer, for providers, hospital, and for public-private partnerships. The overarching issue is that population health management, when done well and evidence-based and comprehensive, it would help reduce the burden of risk and illness in our entire society. It would help unleash financial and clinical resources through the enhanced capacity of physicians and hospitals. It would help improve the health and performance of our nation's workforce. It would help lower healthcare costs and ultimately enhance the vitality of our nation's economy. I wish you well, and now I will turn it over to Dr. Jeanette May. Dr. May?
Thanks, Ron, and thank you to the NDEP program for their leadership role in this topic, and thank you for everyone joining the call today. I will say that there are a lot of folks on the line, and that is so exciting to see so much interest in the topic of population health and public-private partnerships. So my name is Jeanette May. I'm going to spend the next few minutes talking about population health, a culture of health, and public-private partnerships. Ron really focused on, and I thought the data was amazing, on the effects of poor health. I really loved the iceberg slide. I'm going to focus more on the value of good health and how bringing multiple stakeholders together can really enhance that. I have been actually involved in public-private partnerships and healthy community efforts for probably over 20 years. And most recently, I have been honored to be named the principal investigator for a Robert Wood Johnson Foundation grant that was given to the Health Enhancement Research Organization, or more informally known as HERO. So HERO is a research think tank that's really focused on health and wellness in the employer space. But as we all expand our thinking around population health, so has HERO, who's really moved forward and expanded its initiatives into a couple of new areas around sort of healthy workplaces and healthy communities. And I'll spend a few minutes talking about those initiatives. But first, why are we expanding the way we think? Well, it was clear from Ron's slides and the information that he was able to share with us that there is good reason to sort of think differently about population health and to look more at a holistic view that really kind of lends itself to collaboration. I was really excited that Ron mentioned Dee Eddington and some of the work that he has done with Dee in the area of health and wellness. And, Dee has really spent decades working in this space. And I was looking at some blogs this morning, and I saw that Dee just posted a blog, and I don't want to share the whole thing because it's quite long, but it's about health and wellness and sort of the direction that we're all taking with this holistic view of population health. But I do want to share a verbatim quote that comes from that blog. Dee goes on to say, wellness works, so does well-being and culture in collaborative ways. We believe in collaboration, not competition. Evolution, not revolution, and cooperation, not going it alone. So I think that's really important when we look at this healthcare landscape. And as we begin to recognize the value of public-private partnerships in creating a healthy climate and culture and the impact that this healthy climate and culture can have, not only on individuals living, working, and playing in that community, but other stakeholders who also live and work in the community as well. So the diagram here that I have in front of you represents kind of all stakeholders that touch and influence a community, and that community's health and wellness. This was taken from the County Health Rankings, which is an initiative also that was supported by Robert Wood Johnson Foundation. And it's clear here that there are many, many stakeholders that touch and influence the health and wellness of a community. And I think that's really, really important to understand. And as Ron's last slide pointed out, there's value not only to those community members of creating a culture of health and wellness in a community, but there's also value to all of those stakeholders around the circle here. A great example is up to the left we see healthcare. Well, clearly, health systems who are located within communities and engaging employees who live and work in that community want healthy employees in their workspace. But also, they would probably benefit from healthier patients coming in as well. If there's a healthy patient coming in with less comorbidities and less risk, it's very likely that patient will recover from whatever they're in the hospital for quicker with less complications. And we can use that same scenario really for any of the stakeholders around this diagram. And so, as I talked about earlier, I think as we think about population health and about sort of expanding our holistic view, it's really creating an evolution for many of the stakeholders represented on this slide. And I thought that this next slide was a great example of an evolution for one of those stakeholders. And this really is the business case development and evolution for employers and businesses engaging in community health. At the very left is, the lowest level. Years ago, employers engaged in community health sort of from a compliance-driven. But to the right of the evolution, we see businesses sort of actively engaged in healthy community efforts that benefit the community, but also, as Ron clearly showed us, also drives or enhances that business performance. And so I think it's really important to understand that all stakeholders, again, as we expand our thinking around population health, are going through a similar evolution. Certainly public health, which was represented earlier in the last diagram, is going through its own evolution as it's seeing a more holistic view of health in the populations that they serve, and how this lends itself, again, to collaborations with all stakeholders sort of living and working in that community. So, as I mentioned earlier, I'm the principal investigator on a Robert Wood Johnson Foundation grant with HERO that really looks at culture of health in communities across the country. One of the first things that we did is sort of do a scan of the environment to understand what kinds of public and private partnerships are going on throughout the country and how they're engaging and what kinds of impact that we have. And I think what we learned very, very quickly was that the idea and the potential of public-private partnerships is prevalent in many, many initiatives, even beyond the work that we're doing at HERO with RWJS. And I tried to represent some of these efforts that we've learned about through our environmental scan and through other ways that we've looked at healthy community efforts. And I want to chat just about a few of these, but I would really encourage folks who are on the phone today to go and look at the different websites for a lot of these entities, because there really is some amazing work going on in public-private partnership space. Towards the top, there's the Robert Wood Johnson Foundation Culture of Health, and that is part of our own work within HERO. So Robert Wood Johnson has focused its efforts around culture of health and are really looking at ways to enhance culture and climate in communities so that individuals living and working in those communities can make healthy choices. And that choice, that the healthy choice is really the easy choice for those individuals. And all of us really are in the health and wellness space. And making the healthy choice is not an easy thing. And I love the picture that Ron showed earlier of the individual walking their dog while they're driving their car. I mean, it's not easy to make healthy choices. And I've got a great example. I live in a very, very rural area in the Midwest. And as typical of small Midwestern towns, we see about 6 months of cold weather, and we have a very aging population. And as a result, we have older adults who cannot find a place to get out and exercise or take a walk on a regular basis, especially during those 6 months of the year when literally we see temperatures in 30 below and more. And so the Public Health Department, got together with the Business Coalition and a few other folks in town to figure out, how we could tackle this problem in a collaborative way. Recognizing we're a small Midwestern town with no malls, so mall walking is out of the question. We have no YMCA, and we do have a workout facility, but that costs money, and many older adults are on a fixed income. So lo and behold, through this collaborative effort, this public-private partnership, bringing businesses in the community together with public health and the local hospital, we started chatting about other venues where older adults could walk. Again, making the healthy choice the easy choice, making the choice to exercise easy for these older adults. And through a lot of discussion and a lot of collaboration, we created a partnership with some of the local kind of large home improvement stores where they have very big aisles, they have very long hours, and we found that 5 times around the health improvement store is about a mile. And so we invited the retirement center's older adults to come and do walking clubs within these health improvement stores. So even though that's a small example, those are the kinds of things that we've seen really across the United States, really public-private partnerships coming together to solve problems and to make the healthy choice the easy choice for folks living and working in communities. So that's just one example. So let me talk a little bit about down there towards the left on the bottom is Clinton Health Matters. Clinton Foundation is working with, I believe, 5 to 6 communities across the United States, developing very strong public-private partnerships to enhance the health, culture, and climate of communities that all look very, very different. It's an amazing initiative, and I would encourage everyone sort of go to their website and check out what they're doing. There is the Institute of Medicine Population Health Roundtable that is really exploring this holistic view of population health and what it means for our healthcare landscape. I think some of the reports that have been coming out of the IOM Roundtable have really helped us not only understand what is really included in population health, but also how important it is to come together as a multi-sectoral stakeholder group and really tackle population health issues on a broader scale. There's also a lot of work going on through, some folks might have heard of Blue Zones or Prevention Partners. They also work in small communities looking at well-being and prevention and trying to help folks find the right partners to move forward. So my goal in showing this was really to help you understand that this is really a movement towards enhancing health at a population level through public and private partnerships. And that it's a win-win for everyone. And I think some of Ron's slides, especially the last slide that he had, really demonstrated the value to those stakeholders engaging in these initiatives. And as I mentioned earlier, the Health Enhancement Research Organization, has several initiatives currently going on in this space, and I want to talk about a few of those. The first one is healthy workplaces and healthy community. And the goal of this project is to create a website that will offer lots of really great information to employers and to other stakeholders really interested in engaging in these kinds of efforts, culture of health and healthy community efforts. This is the landing page for this new website, and the website is not live yet. I believe it will go live very, very shortly. And the goal of this website is to offer best practices, case studies, some thought-provoking discussions, and a lot of really great resources that will help employers and other stakeholders come together to work on healthy community efforts. When we were doing our environmental scan, we saw so many great resources that really would help folks become engaged and really have an impact through these kinds of efforts. things that have come out of the Federal Reserve, the collective impact model, and so many others. One goal of this website is to bring all those great resources together, almost sort of in a one-stop shop, so that folks can take a peek at everything that would help them enhance their current collaboration or create some new efforts within their communities. The second initiative, and the one that I'm spearheading as the principal investigator, is a project that looks at exploring the role of measures in culture of health efforts around the country. This is our work, Heroes Work with Robert Wood Johnson Foundation, and it's a three-phase effort. The first phase of the project, and I touched on this a few minutes ago, was an environmental scan of kind of what's currently going on in the healthcare landscape around public and private partnerships to address healthy community efforts and culture of health efforts across the United States. We had an opportunity to meet so many amazing efforts and to chat with so many great folks from all different stakeholder sectors about how they're engaging in these efforts. And we put that together in a pretty comprehensive report that really sort of gives a lay of the land on what's going on in culture of health and healthy community efforts across the country. And that is available on the HERO website, and I also believe that it's available on the Robert Wood Johnson Foundation site as well. Through that first phase, we were able to identify really subject matter experts who were working in these efforts and had a sense of really what worked well and where they were struggling or where there were challenges or barriers. And our goal was really to take a look at the measures, because ultimately we want to identify measures that resonate with all stakeholders in these efforts and that really help to engage those stakeholders early on in the process of creating these collaborations, and then measures that will encourage those stakeholders to stay through the implementation and really add value to the collaboration, but also to that individual stakeholder's organization as well. And so through our environmental scan, we identified 3 groups of subject matter experts. And we worked very iteratively with those SME groups to bounce ideas from measures off of those folks and tweak those measures so that at the end of our second phase report, we had a series of measure concepts that could be used in culture of health and healthy community efforts to initially engage employers and other stakeholders in these efforts, but also could be used to measure the impact of those efforts, and those measures would specifically resonate back with the employers and the other stakeholders. And we did find that there were challenges in engaging all stakeholders, especially when there wasn't a common language and that measures that were currently used in these efforts really didn't resonate with stakeholders around the table. And so we clearly see this as an opportunity to enhance public-private partnerships and help move the entire effort forward. So that second report has just been completed, and we're entering phase 3 of our work with Robert Wood Johnson Foundation now. And our phase 3 work is to begin to informally test the measure concepts that we identified in phase 2. And so these are concepts, again, that can be embedded in culture of health and healthy community efforts to help those efforts engage, multiple stakeholders across the board. So we are going around the country interviewing different sites and asking folks to work with us to informally test these measure concepts. So hopefully by the end of the year, we'll have a final set of measures that these healthy community public-private partnerships can utilize as they're engaging stakeholders and moving forward in their efforts to create, healthy cultures and climates in the communities where everyone sort of lives, works, plays, and prays. So we're very, very excited about our work with Robert Wood Johnson Foundation, and I think it's really exciting that, that HERO has partnered with RWJF and so many others to help move this work forward. And I really can't thank you enough for taking some time to listen and to hear about our work. Please, visit our website and see some of the great reports that we have been creating as a part of this work. And I think I will hand it back to Pam now.
Thank you so much, Dr. May and Dr. Loeppke. Now I want to talk about some of the resources, and we will also have time for some question and answer as well. NDEP has developed many resources for people with diabetes, for providers and for consumers, and everything is in the public domain. So we would love for you to come visit our websites. Our first website is the Diabetes at Work website, and let me repeat that all of these slides and recording of this presentation will be posted on the Diabetes at Work website as well as the general NDEP website. We have some clearance issues at CDC, so it may be a couple of weeks, but we will be sending all of the participants a link as soon as these slides are posted. So the Diabetes at Work website actually is 10 years old. It was established because folks said we need to unite the two worlds of diabetes care and then the world of the work site and businesses, because at that time there really wasn't anything that spoke to the needs of folks at the work site. So then a couple of years ago we said, well, this needs a major revision, and we asked a whole bunch of experts in many different sectors to help us. And as I said, Dr. Loeppke was the chair of this. They brought up topics. They brought us things that we wanted to cover. And we'll go over the details in a minute. But this is one website. We'd love for you to go to the Diabetes at Work website and give it a spin. The other is the general National Diabetes Education website, and you can find all types of materials from behavior change to nutrition. We have information for providers. We have all types of tear-off sheets to educate consumers, let's say, about their eyes, about their teeth, about their feet, etc. So we really would love you to come visit. We also have a website about the primary prevention of diabetes. As Dr. Loeppke mentioned, we can prevent type 2 diabetes in people who have prediabetes, folks who are at very high risk. We also have to remember that prediabetes is also a risk factor for cardiovascular disease as well. So please come and visit our general resources as well. Here's our Diabetes at Work website, and as Dr. Loeppke mentioned, depression is one of the major contributors to decreased productivity. And we just happen to have on our Diabetes at Work website a continuing education program, and somebody asked if there was CE for this presentation, and no, there is not, but there is a presentation on diabetes and depression at the work site that does offer continuing education, and you can access it through the diabetesatwork.org website. So I wanted to bring that up because that was a question that we received in the chat. So if you first go to the diabetesatwork.org website, we tell people, well, what is the website? What do we want people to find here? And it's a resource of things from CDC, National Diabetes Education Program, but we're also trying to be almost like a clearinghouse to connect people with other programs, such as NIOSH, National Institute of Occupational Safety and Health. CDC has a National Healthy Worksite program as well. So we have compiled many links to help people look at various resources that can help them either establish a program at their own worksite or have resources for programs that are already established. When we asked the folks who registered how they got materials, many said that they worked with contractors, with vendors. Some said that they get their resources online, and some actually have occupational medicine professionals on site. This website can help everybody because it will have resources that you can download, and you can even put your own logo on if you would like to. We will be continually updating it with news articles, new numbers, etc. We have resources like a game plan, fat and calorie counter. That's very popular. People want something so that they can track their progress. We have lesson plans about foot care. We have lesson plans about nutrition. We will be developing more lesson plans with the occupational health nurses to serve their needs as well. We also have a new feature about Ask the Expert. Our stakeholder group folks are very, very loyal, and for the past 10 years, every question that has come in to Diabetes at Work has been answered by a real person. So that if you do have questions, eventually somebody will really answer those questions. We have information about diabetes basics, from the definition of diabetes, how to prevent type 2 diabetes, emotional health of folks with diabetes, and also diabetes and pregnancy, because at some work sites that might have a lot of women in childbearing years, certainly diabetes and pregnancy, gestational diabetes is an issue. So we have information about that as well. We have materials so that you can plan a program. So you want to understand your environment. You want to make the business case. There are resources there for you. We want to help you build your worksite wellness program. So how do you develop a culture of health, a culture of wellness? What are some program activities that you can do? And how can you connect with the community as well? So we would really love for you to go on to the National Diabetes Education Program's general website and the Diabetes at Work website and just kind of navigate, explore, and see what you can find. So I'd like to start out with some of the questions that we received. The first question that we received is, how do you measure presenteeism? I believe Dr. Loeppke had brought that up. And presenteeism is when people are at work and they are not performing at 100%. So I'm going to turn it over to Dr. Loeppke.
Okay, thank you, Dr. Allweiss. So, yes, there are actually several validated instruments, questionnaire tools that have been shown to effectively measure presenteeism. There are different ones. One is from Dr. Ron Kessler at Harvard Medical School, and the tool that he put together along with the World Health Organization is the HPQ instrument, stands for the Health and Work Performance Questionnaire. There's also a tool by Dr. Ken Pelletier called the Stanford Presenteeism Survey, SPS, as well. Another one by Dr. Deborah Lerner from Tufts University called the Work Limitations Questionnaire, the WLQ. And there are others. So these have been tested and again, validated with some objective measures of workplace performance and have been shown to be very effective measures of the presenteeism impact that an individual is experiencing. And then you can see how various populations actually over time, sometimes pre-post intervention of an initiative could be measured in terms of presenteeism impact. So unless there's other questions or you have other thoughts, Dr. Allweiss, I'll leave it at that.
Well, that's perfect. In Diabetes Work, we do reference a couple of those, but we will collect these and we will have the exact links for everybody. So afterwards, Dr. Loeppke and I will compile these links for everybody, and we will put them under the presenteeism section. The next question is, would you speak to the lexicon challenges among stakeholders so that communication is optimized? So I guess that's kind of what are some of the barriers that folks might have, that communities and work sites might face. So I'll turn it over to Dr. May.
Great question. And I think that's a really interesting question as well, because I took it to mean, how does sort of the language barriers that exist in these kinds of collaborations? And the reason why I think that way is because we actually HERO convened a variety of experts to talk about challenges and barriers and creating, sort of the business case for stakeholders to engage. And one of the findings of that convening was that language is really a challenge when you bring lots of different stakeholders together. So I have a master's in public health, and I actually teach public health for a master's program at a university. And I also, early on in my career, I worked in a large integrated delivery system. And I can tell you the language that is spoken in a health system, the language that is spoken in a public health department, and the language that is spoken in an employer setting are all very, very different. And when we interviewed different healthy community efforts around the country, and we asked them, what are the challenges that you face when you try to bring stakeholders together, the number one concern was the idea of, we think this is a good measure, but they don't get why this is an important measure. And it wasn't really so much about the measure as it was about the language. I do believe, and there's a lot of really good research out there on this topic, I really do believe that measures can work to sort of rally the troops around a common goal, a common language. And I think that's why, HERO was so excited to receive the grant from Robert Wood Johnson, because we do believe that the right measures that truly resonate and are able to be understood by all the stakeholders around the table in these efforts really will rally the troops and will eliminate a lot of those barriers that these stakeholders face when they come to the table with different views and, different ways they think about things. So great question. Thank you for that.
Dr. Allweiss?
Yes.
Thank you for that response, Dr. May. And just to add, it stimulated a thought that really in work I've had an opportunity to do across different stakeholders, so employers or hospital health systems or health insurance companies or individual patients and consumers in my practice over the years, these other public and health department public-private partnerships. A common framework that I hear resonate is what really Dr. Don Berwick talked about in terms of a triple aim for our nation in terms of health. And I think everyone's familiar with that, but in essence, the triple aim that he talks about is the fundamental underpinnings of population health management. That triple aim is better health for the whole population, better health care for those that have conditions that need care, to generate better value, higher quality, and lower cost. And when we think of all the different stakeholder roles, that's a very common language and framework and laudable goal that each would benefit from, whether they're an individual, a family, an employer, a community, a state, or our nation.
Thank you. That was a wonderful summary. We just have two more questions. For Dr. May, what were the three areas you identified in Phase 2 of HERO?
Oh, great question. And these are measure concepts. So, yes, they are more areas than they are actual formal measures. But they do focus, and again, they are sort of in two buckets. One bucket is those measures that incentivize folks to come to the table initially, and then a bucket for those measures that encourage them to stay. And so I will say that that first bucket focuses on, measuring, demonstrated commitment, having the right convener, and sort of understanding the strength of the collaboration and the commitment to the collaborative effort as well as health and wellness in general. And then the other bucket, which are some of the measures even that Ron touched on in his presentation, are what are those measures that resonate and hold value for all the stakeholders at the table. We do believe that those vary based on the needs assessment and the identified goals by those community collaborative efforts. But ultimately they are about, those high-level quality of life, productivity, safety, and performance things. And somewhere in between, they're about who in the community and who of those stakeholders is committed to health and wellness, and how can we utilize those employees to become advocates and champions in the community efforts. But again, really, there are concepts right now, and that's what we're exploring. And I would definitely say check back on the HERO website, like third quarter of this year, and we'll have a lot more detail for you on it then.
Thank you. And we will also post the HERO website on the National Diabetes at Work as well. We have two questions. One is, do you have any curriculum for chronic disease management population-based? And definitely improvingchroniccare.org. Dr. Ed Wagner's program has a lot with the chronic care model. You can find information there. Another question is there a benchmark for developing a results-oriented program that is definitively measured change through data to demonstrate to stakeholders, because this is very important. So both of you can answer that. So whoever wants to go first, take it away.
Ron, be my guest.
Okay. One follow-on thought to the prior question, even about chronic disease management, population health management. There are some great resources out there. The American College of Occupational Environmental Medicine does have educational resources and even some training curriculum around health and productivity management and population health management, and will have increasing levels of resources in the year ahead. In addition, there's a textbook on population health management. It's on one of my slides, so when it comes out, the reference is on there, but it's called Population Health, Creating a Culture of Wellness. Dr. David Nash is the editor-in-chief of that book. So anyway, those are a couple of thoughts. In terms of benchmarks, again, just one I would offer as a reference for later, and it has a compilation of other references built into it, is a published article that came out in September. Dr. Ron Getzel was the lead author. I happen to be one of the co-authors as well, but many people that put together, the title of the article was, Do Workplace Wellness or Health Promotion Programs Work? And so it's in the Journal of Occupational Environmental Medicine, and I'll make sure and give you that because it helps establish the kind of benchmarking and the kind of data elements and metrics that are encouraged when you try to evaluate the impact of any intervention pre-post. So with that, I'll turn it over to Dr. May.
Oh, sure. And just to add that from a community perspective, I do think this is something that we are working on, and that I showed the landing page for the HERO Healthy Workplaces, Healthy Communities website. So no formal benchmarking exists unless you look at county health rankings from a community perspective. But I do believe that HERO is working towards creating a database, if you will, of best practices and sort of comprehensive case studies that will give the underpinnings and the framework of some successful programs. And we hope, with measures as well, that folks can use to demonstrate to stakeholders, this works, we think we've got it right, come on board and lend us a hand kind of thing.
Well, thank you so much, and our time is up. I want to thank our speakers. I want to thank our audience, and I want to thank National Diabetes Education Program. Please fill out the survey that you will receive immediately after this call. It helps us improve all of our programs. And if you do have any other specific questions, please email me. My email is on the last slide, pca8@cdc.gov, and we will have one of our speakers answer the questions. Thank you so much, everybody. Bye.